Hello. Hello.
Yeah. Are you able to
Vishal,
hear me?
we are seeing you.
Yeah.
Yes.
Yeah, hi.
Hi.
Who's on the other side?
I am Dr. Sham Somani.
Hi, Dr. Samani, how are you?
Hi. Fine. Fine.
Very nice. So, shall I start my case?
Just brief the details about the case.
All right. So, this is a 6-year-old child with history of obstructive symptoms because of grade 4 tonsils and almost grade 4 adenoids. So, I have already performed intracapsular tonsillectomy because I was only asked by Prasad to demonstrate adenoidectomy. So, I have already performed intracapsular tonsillectomy. Now, I'll proceed for adenoidectomy. The patient is orally intubated. There's a Boyle Davis mouth gag already fixed. Nose is decongested with the patties. And now I'll demonstrate the bending of the wand for the adenoids. So this is the length of the, I'm using EVAC 70 standard extra HP wand because this is the wand that majority of the people use. So you have to bend it at the junction of the proximal, say 2/3 and distal 1/3. And you cannot bend it acutely like this. You have to make a gentle bend. So you can, I'm just trying it to show to you so that you have to make a gentle bend by around 30-35 degrees in the distal 1/3. So if you do this, then the tip of the wand will reach the superior part of the adenoids. Now, can we have the internal picture, please?
Excuse me, sir. Moderators for next session are Dr. Amrapali Pawar, Dr. Girija Ghate, and Dr. Neelam Sathe.
Oh, very nice. Hi, Amrapali, Neelam, and Girija. How are you?
Good morning, Vikas. Amrapali
Hi.
here.
Hi, Amrapali.
Hi,
Tell me, are
Girija
you
here.
able to see the picture?
Girija
The
here.
endoscopic picture? Hi, Girija. Are you able to see the endoscopic picture?
Yes, we can see.
All right. So, see, this is the adenoid. I have pulled the soft palate with the rubber catheter. Therefore, you can see some space. And we have already given some oral steroids to the patient so that the size of the adenoid and the vascularity has already come down. All right. But still, you can see this is still almost a complete block.
Yes.
And let me show the other side as well before I start. So,
Vikas, the audience is asking about intra and extracapsular tonsillectomy.
all right. So, I have performed intracapsular tonsillectomy on this child. This is the intracapsular tonsillectomy. Can you see that I have not removed the last layer?
Okay.
I have gone till the, this is a completely painless and bloodless procedure. I call it CCIT, complete intracapsular coblation adenoidectomy.
Okay.
Vikas, just sorry to
tonsillectomy.
interrupt you. Just 1 minute
Yeah.
because we are feliciting the chairperson for the previous session.
Yeah, no problem.
Just
No
a minute.
problem. No problem. Take your time.
Can I have the voice for a minute? Hello?
Hello?
Yeah, okay. This is the last bit of a thing. We can see this is a coronoid which we are trying to take out. This is the tip of the coronoid process. Can you focus it? Yeah. So once you get this out, you are absolutely sure that the whole of the temporalis pool is gone. And you can also see the mouth opening now. Can I have the scale? So the mouth opening has come from wherever we were to almost 5.
Yes, sir.
So that's what the target should be. So if I keep it at 5 now, eventually maybe this is 4 fingers. Eventually all the pain and the physiotherapy, we still will get some loss and maybe settle somewhere between 3 fingers to 4 fingers. Now the next bit is Dr. Sudhanshu Kothe will take over, and before he scrubs, I will just get the last molars out. Dr. Sanjog will do that, but I want to show you how we trim the coronoid apex. Can I have the drill again one more time? Because you can't keep it rough there. So magasa motha wala. So the apex of the coronoid which has been excised, now the coronoid itself need to be smoothened out. And these are the standard autological instrument, nothing great about it. नहीं उसको ऐसे करो ना, ऐसे नहीं, एक मिनट, ऐसा इधर, yeah. Create a space there, yeah, that's right, yeah. And see, when you do that, you find something else. Can I have the cautery? You again find some fibers. If you see those fibers, ensure that you remove them. Because if you don't take those fibers down, you still not get the mouth opening that you desire to have. And you see usually these fibers, yeah. Now having seen that, now I'll start, उसको पीछे ले जाता हूँ, yes. नहीं ऐसे नहीं ऐसे नहीं, मैं बता रहा हूँ, ऐसा, yeah. Like that, yeah. Now that's the tip which I will sort of drill out. कोई बात नहीं, you have done it, yeah. ये देखो, ठीक, yeah, wash. Yeah, okay. Now, yeah. Yeah, yeah, okay, that's fine. And it's about, you can see it from a distance. Can you bring that camera down now? Just to show the mouth opening now. नहीं इकडनं या बाजून ये.
May I request Dr. Jalil Mujawar sir to please felicitate our chairpersons.
असं ठेव एक मिनट. 5.5 आ गया यार लगभग. नॉट बैड. 5.5 हो गया लगभग. नॉट बैड. ऐसे हाँ राइट. अभी कोठे सर को देना आपने.
Dr. Rajendra Ghumre sir and Dr. Venkatesh Polawar sir.
वो तब ये दांत निकाल देना है. नहीं अभी पहले गॉस पीसेस निकालने हैं सब. रुक जा. या So this is almost 5.5 fingers, yeah. Yeah, that's what I'm going to talk when my mic went off. Okay. When you do this, just a minute. Ek minute, look, when you do this, you ensure that this is happening this way and not, say, if I go more, I may end up dislocating it. So you always ensure that you are not dislocating as we go. Because if you dislocate the TM joint, then the problem comes of physiotherapy post-operative. Then the patient has to be put on a barrel bandage and then it completely fought. You are lost the game. So you ensure that you don't dislocate it. You only stretch your lug so far that the joint is not dislocated. Because if you dislocate the joint, there is a problem post-operatively.
No, but
you are absolutely right.
That can be relocated, sir.
It does, but then again what happens, it's painful, patient's motivation goes down, and for a few days we don't want to give a rest because every time he tries to open the jaw, he dislocates. So it's a problem, and the best way not to get into it is not to stretch your lug too much and attempt for 5.5 and a 6 finger. Be happy with the 5 finger.
So you know, we had one patient who had a recurrent dislocation. Then for that, we have done an amnectomy.
Yeah, that's
for the
right.
same patient,
Yeah.
and patient recovered.
That can be done, but again, you see, nobody wants 2 surgeries, 3 surgeries.
Yes, sir.
And as it is, see, from the first surgery of this, when he comes out of it, He's already fairly troubled. I mean, to tell him that I do one more surgery on you is not so easy, particularly if you are in a sort of a setup where your patients are more aesthetically or they're not that cooperative in the sense. And also the cost part of it. Now what we have done is we have removed the molars from the upper side, and I'll introduce Dr. Kothe to you. He's getting scrubbed. He is with me, and together we have done a book on management of
Hello,
this.
can we have a PIP picture, please?
Hello, may I request
Hello.
Dr. Anil Patel sir and Dr. Gaurav Patel sir to please chair the session?
Yeah, hey, good morning.
Hi, so we are back with you again.
All
You may
right,
start.
very nice. All
Sorry
right.
for the delay.
No worries, no worries. So basically this patient is a 6-year-old child and I have already shown the bending of the wand. Can I have the endoscopic picture now? So I'm going in from the right side, as you can see, with a 0° 4 mm endoscope, and you can see the adenoid is almost a grade 4 adenoid. I'm starting from the superior pole. So see, that's the superior pole of the adenoid, and we first make sure that the wand is actually reaching the superior pole. So that we'll start with the
Can you please
superior
show
boundary of
Can
the...
you please show the retraction externally, non-endoscopic? How the palate is retracted?
All right.
Yeah.
All right. Can you see that?
Yes, we can.
All right.
Yes, thank you.
Why this retraction is important, so that can you see, this is the insulated part of the wand.
Yes,
This is the passive electrode. If this is touching here, then you may
Yes.
get a burn on the soft palate. That's why we retract it. Otherwise, there is no need to retract.
and do you
All right,
always
so I'm
use
starting-
4 mm scope or you use a pediatric one sometimes?
So this is a 4 mm because it's a 6-year-old child. In a very small child, I use a 2.7. But most of the kids from 3 year onwards, you can use a 4 mm scope. Now this is the eustachian tube. This is the torus tubaris. So I am starting with the superior pole. Now see, I have come right till the periosteum. Can you see this?
Yes,
Yes.
The boundaries that we defined in 2016 paper, which was the first time the adenoid surgery boundary was defined, and that's our Indian Journal, March issue 2016. So the boundary is the periosteum of the sphenoid. Can you see the periosteum?
Yes.
If you go till the periosteum, but do not open it, then the chances of recurrence is absolutely minimal, because I have completely removed the adenoids from the superior boundary. All right?
Yes.
Now let me just debulk a little. So now the superior boundary of the adenoid is defined. Now the lateral boundary of the adenoid is torus tubaris in the anterior part. So I am removing the adenoids from the lateral boundary. Anteriorly is the torus tubaris and posteriorly will be the fossa of Rosenmuller. Now see, this is the eustachian tube orifice. This is the lymphoid tissue. So you are not supposed to get into the muscle, but I am removing the lymphoid tissue completely. All right?
Okay.
This is the lateral boundary
so if you
anteriorly.
miss that lymphoid tissue, is there a greater chance of recurrence or blockage?
Absolutely, absolutely. Therefore, if you remove it, so I am going till almost, you can see 4 to 5 millimeters from the eustachian tube orifice, but I am only submucosal. I am not
Yes.
getting into the muscle. If you get into the muscle, you will create fibrosis, which obviously you do not want. Right? And now let me debulk. All right? So just as we do for mastoid, and you see it's full of vessels, right? But you don't need to bother. You keep on working. I have not used coagulation so far.
I was just going to ask you, do you stop and use coagulation or you just keep cutting?
No, I did not. I
Yes.
did not. You saw. In fact, I'll try to make it bleed once again. If I work fast, it might bleed. I'll try to show you a bleed. Only for demonstration.
True.
If it bleeds, it bleeds. Now, this is the lateral boundary. This is the torus tuberous, and layer by layer I am getting into the fossa of Rosenmuller. So that's the fossa of Rosenmuller. Layer by layer. Now you have to look for the pulsations of the internal carotid. Sometimes it can increase the saline flow. Put it to maximum. Now see, that's the superior boundary completely defined on the right side. That's the fossa of Rosenmuller. That's the, now if the internal carotid is medial or dehiscent, it will come here, it will not come here. So be little careful and always see the tip of your wand. Never dig the wand blindly anywhere. So now I am going for the posterior boundary and the fossa of Rosenmuller both simultaneously. This is the fossa of Rosenmuller. I am not digging into it. I am removing the tissues from the posterior boundary, which is the buccopharyngeal fascia also, so that the whole area is completely open for me. And believe me, adenoidectomy is one of the most satisfying surgeries in ENT, because 15 to 20 minutes of work and the child starts breathing normally. It's one of the most satisfying surgeries in ENT. Now see how deep I am going. Can you see this?
Yes.
Yes.
The fossa of Rosenmuller.
Vikas,
So
had
many
you ever operated a recurrent case of adenoids?
Yeah, once in a month I do.
Right. How tough it is to do that?
Not really, because many times people have not gone too much inside. But at times when the child has already grown old, anyway the adenoids become tough.
Right.
So it's not difficult at all. But obviously in an older kid, the adenoids will be more tough.
Tougher. And do you
Now
see
see
a
how
lot of,
deep I am going.
Yeah, yeah. And do you see a lot of cases of adult adenoids too?
Very, very, very common. In fact, I have 3 adenoids today. After this, I have a septoplasty with adenoidectomy in an adult.
Uh-huh.
Then again, I have a child.
What do
Yeah.
you think is the cause of adenoids in adult
No,
patients?
no, because they are persistent. They are only, it's a misnomer, misconception that the adenoids are supposed to regress always.
Okay.
They do not.
Or do you
It
think
may
What
regress,
is the
it may not.
recurrence rate? I mean, how many do you generally see as recurrence of adenoid after they have undergone surgery in adulthood? Like they've undergone a surgery in childhood, but they still have adenoid recurrence after they grow up.
No, it's not recurrence, it's the remaining part of the adenoid.
Okay, remnants.
No, adenoids cannot
they have never
recur
been
unless you
removed.
leave them. No, 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 no. If you remove them completely,
Yes.
they will not recur. At least to the extent requiring another surgery, no. Now see, can you see the buccopharyngeal fascia all around?
yes, yes.
That's the fascia. I'm not opening the fascia, I'm only defining it for you. All right?
Yes.
Still some adenoid is there in the fossa of Rosenmuller. Now, around 10-12 years back when we were discussing about the boundaries, then lot of people ridiculed that, oh, it's not skull-based surgery, why you want to remove each and every bit? And my issue was that why not remove each and every bit? If you are doing some surgery, do it completely.
Right, right.
So, fortunately today people are all accepting it, and I'm very thankful to our community that it's very difficult for a parent to understand why a surgery has to be done again,
Right.
or why the results have not. And you see how nice you can see the fascia in every single case.
Absolutely.
It's a natural boundary. Unfortunately, it was not described earlier.
Right.
Now the right side dissection is complete. So I'm just doing as much as I can finish from the right side before I shift to the left. So the boundaries are already defined on the right. All right? So this is the passivant ridge, which is the inferior boundary.
Vikas, again, sorry
Yeah.
for interruption, but Dr. Kapre is operating on the other side. He just wants 2
Yeah,
minutes
yeah.
of the time. So we'll
No
keep
worries.
you in PIP and he will
Sure.
be on screen right now. Just 2 minutes.
Sure.
Dr. Kapre.
पैटी दे दीजिए ना उधर। इसको क्लीन करिए अच्छे से। क्लीन करिएगा उसको।
Can we have the other OT,
Hello?
no,
Good
full
morning.
view of the other, Dr. Kapre?
Yeah, Dr. Kapre, you're on the screen.
Yeah. Can you hear me?
Yes, sir.
Yeah. Okay. We got about 5.5 fingers opening centimeters, but now the problem is how to keep it, because it is one job to make it 5.5, but it's quite another job to maintain even up to 4 or maybe 3.5. So to do that, whatever gap we have created there has to be now completely sort of patched with a healthy lining. We discussed about the options. Dr. Kothe is a very eminent, and together we have done a book on surgery of trismus in OSMF. It is worth mentioning that this is not a very well discussed topic in any of the forum. So it's a worthwhile asking Dr. Kothe, why palatal flap or why platysma flap? Why not fat flap? Why not nasolabial flap? I'm sure he will be all happy to answer questions. But right now he has put in his, we have removed the molars, the upper molars, not the lower molars. And I hand you over to Dr. Sudhanshu Kothe. He's an eminent head neck reconstructive surgeon. All you.
So I'm Dr. Sudhanshu Kothe, plastic surgeon from Nagpur. We have been doing trismus surgery since last 2.5 decades. Must have done a few hundred. We also written a book, as Dr. Kapre mentioned. Now, the problem here is, once you have released the trismus, once you have released the contracture, you have defects in the cheeks. These defects usually are mainly in the retromolar area where the thickest bands are present, but the contraction and the loss of tissue or the inadequacy of tissue in the cheek may extend right into the commissure area in the entire cheek, or it may go into the soft palate also. So now, in this case, we have enough cheek mucosa present, but in grade 4 trismus, there is no mucosa left. So when you incise and release, you have nothing, no cheek mucosa left. So the biggest challenge now is to put good thick, full thickness lining to cover these defects. If you do not cover, as we know, there is always failure. So we put in some tissue which is full thickness, which has its own blood supply and maintains the size of the areas that are important to us, which is the retromolar area in this case, but it may be the entire cheek in grade 4 trismus patients. Now, what is the choice that we have to put here? Skin graft is out of question. It is not full thickness and it cannot maintain the parameters, and also it has its own problems. So we should have some flaps in this area. So what are the flaps available? The first flap that we see here, see now the defect is posterior, right into the retromolar area, both sides. It's a triangular defect. Maximum width is at the place where the retromolar area is, and there is a tongue of tissue which we require anteriorly a little into the cheek. This is the usual grade 2, grade 3 trismus patients will get this kind of a defect. If you have loss of tissue in the cheek also, then we may replace that with something. So now we have palatal flaps which are easily available to be put here. The pedicle of the palatal flap is actually opposite the second molar in the palate. So this is the pedicle, this is the pivot point of the palatal flap. So now naturally this much tissue goes into, transposes into this tissue, and this tissue, the healthy mucosal tissue of the mouth itself, naturally which is present inside the mouth, is replaced and given to the defect. The other choice that has been discussed often is the nasolabial flap. Now imagine the nasolabial flap is outside here. The pivot point lies here. From here you are trying to provide something here. Even if you take a long flap, the business area of the flap, which is here, the best part of the flap, does not reach posterior. The last part of the flap reaches posterior. So there are chances that we may not get good enough tissue, plus we have to violate the entire area in the cheek to reach there. On top of that, we have scars outside, external scars in the cheek. All these things do not augur well. the easiest thing now is to put simple palatal flaps in this patient. Now, if you have loss of tissue in the cheek, which needs to be replaced from posterior to anterior, and there is a width required about 3 centimeters or so, then we take platysma flaps from the neck. The platysma flap, the skin is taken from the lower part of the neck, and there is no incision except a transverse incision in the lowermost part of the neck. So aesthetically it is perfectly pleasing. The platysma flap is a musculocutaneous flap which is very healthy, and the skin gets transposed inside the cheek. You have a lot of skin available which could be taken from the neck and transposed into the cheek. Today we are going to proceed with the palatal flaps. I'll talk about the palatal flaps step by step. I'll be most happy to answer any questions. Blade, please.
Sir, can we just interrupt you for 2 minutes and
Yes,
go over
yes.
to the adenoid surgery?
Certainly,
There are some
certainly.
questions for Dr. Vikas.
Yes, yes. Thank you.
Hello, Vikas? Hello?
Child is into, yeah, hi, I
Vikas,
could not
yeah,
wait
yeah.
because
So there is a
the
question
child has
from
been
you for
intubated for the
that.
last 1.5 hours, na?
Hello?
No, I'm saying that the
Vikas?
child was intubated.
Yes, I
Child was
understand.
intubated for quite some time, so
I
I could not.
understand, I understand. No, actually, there is a question for you from the audience.
Yeah.
So,
Yeah.
two questions actually. First
Yes.
is, can you please tell us the details of boundaries, how you identify of complete adenoidectomy? And second is, are there any special tips to prevent damage to the passivans ridge?
You are absolutely correct. So see, this is the passivans ridge. Can you see that I have not got into the muscle?
Yes.
This is the last bit of tissue, and when you do it is, can you see the contraction?
Yes.
So you have to be careful that you should not go into the muscles. So if you are not sure, you can push it like this and then operate. See, if I have to take out this area,
Yes.
I am pushing it with the wand so that it does not come in my way, right?
Yes.
I have removed everything. Now see, I just out-fractured this inferior turbinate because this was on my way, and therefore this little bit of amount of ooze was there.
Yeah.
So on the right side, I didn't have to do that, so there was not a single drop of blood. So now the boundaries of adenoid, the superior boundary is the periosteum below this sphenoid bone. You can see it
Yes.
very, very well,
Yes.
right? The lateral boundary anteriorly is the torus tuberis. This is the eustachian tube orifice. 4 to 5 millimeter of mucosa you have to completely preserve. Now I have not gone into the muscle at all. The lateral boundary posteriorly is the fossa of Rosenmuller. You see it is completely cleared.
Yes.
Posterior boundary is the buccopharyngeal fascia. You can see the buccopharyngeal fascia everywhere very clearly, and inferior boundary is the passivans
Passivans
ridge.
ridge.
And in this area, the moment you touch, you will see the contraction.
Okay.
So you should not let the muscle contract and come in your wand. Now with this, if you do this kind of a job, you can remain very, very sure that this patient will not have symptoms and will never ever require a revision surgery.
True.
Never ever. I am making it very, very, prominent. But I have done thousands, and if you go do this, you can actually guarantee that a revision surgery will not be required.
True.
So now we should be getting into guarantees. Gradually, medical science cannot be said that when we are doing some things, fine, allergy can be still there, but then you can always manage with intranasal corticosteroids.
Yes.
All right. So external camera, please. I'll take my mask down with your permission,
Please.
so that surgery is over. So I'll take questions. And you saw how much the surgical time would be, what, 15 minutes? So it's not a very time-taking surgery. It's a wand-consuming surgery. So obviously, you spend wand. If you do not want to do that, you can do it with a debrider, wait for the hemostasis, and then you can use the wand. But getting the final boundaries of adenoids is very, very important. You can do a painless, bloodless, and recurrence-free surgery in every single case.
Is there a big learning curve, like people who are beginning to use Cobblator? Any tips for
Yeah.
them?
Yeah, so there's a learning curve. You have to understand it's a new instrument in our armamentarium. What I could demonstrate today, I was not able to demonstrate 15 years back.
Yes.
When I started with 16 years back, 2008 or 7 when I started, Dr. Vanita, can you step here in front of the camera? This is Dr. Vanita, mask down please. This is Dr. Vanita, wife of Amit Seth, our ENT colleague. She cursed me like anything. Arey, kya kar raha hai? Why are you wasting so much time? So she is.
I think that's the story with everybody who
Absolutely.
started doing coblation.
Absolutely, absolutely. So she also leave it, do it your regular way. Forget about coblation on adenoid tonsil. Do it your regular way. So Vanita is, testimony that you always take time. We would have taken what 50, 100 cases, Vanita, easily, for our hands to set on. So that is the only message. You have to learn the right technique from the right people and give it time. You cannot do anything in a day. And if you do everything, you will be master of none. You have to be master of one and the jack of everything else. You cannot be master of master of everything you cannot be. You will remain jack of everything. That's what you have
Well
told.
said, Vikas. So any questions from the audience? No questions, Vikas. Everyone.
Thank you very much.
Vikas,
Just one question, one question,
just
please.
one question, please. Yeah.
There is a combo method also, no? Debrider and then cobbler.
Yeah, absolutely no harm in that. Suppose if the adenoid is very large and you obviously want to restrict the uses of your wand, you want to use the wand in other case also, or suppose if it is a non-affording patient and you are using the wand which is already used in one case, you would re-sterilize it by using ETO, which we also do, and use it for non-affording patient. In that, we sometimes debride the whole, adenoid till the first layer 2, like Satish has described, then pack it and wait for some time, and the last layer we do with the coblation. End result will be the same.
Sir, one more question. Sir,
Yeah.
what is your observation for the recurrence? The case done by the coblation and the case done by the debrider?
No. It is not the tool. It is tool behind, it is the hand behind the tool and the brain behind the hand, which is more important. So we, from 2001 to 2008, we were doing debrider adenoidectomy only. That time there was no coblation. But we made sure that we removed each and every bit and coagulated it with suction cautery. See, Satish did a great job with the debrider and the last bit with either coblation or cautery. You will get the same result as what I am getting. There is no difference in the result. I do it at times. So these are only different tools. You have different possibilities. It is your hand and the brain behind your hand which is more important.
And the healing time for the both procedures?
See, if you cauterize after doing debrider adenoidectomy, then the healing time will be a little more because you have cauterized. That is 350 degrees centigrade. This is 60 degree or 70 degrees centigrade. So obviously, healing time will remain the same, but the pain and the inflammation will be much less in coblation because of the temperature. If you have not cauterized much, if you have only cauterized a few twigs here and there, healing time will remain almost the same. There will be no difference. So again, I am telling, you have a Mercedes, you have a Honda City, you have a Alto, Maruti, you will still reach the same place. That's what is the most important thing to understand. So there is no, I cannot afford coblation, so I'll not do a good job is not to be acceptable. You learn to do the right thing with the equipment that you have. We also started with a big zero. So what? We still get the good result. You can't blame it on the instrument. It is you, the surgeon.
So basically the
Your
take-home
commitment.
message will be, you have to check whether you have cleared off all the boundaries like you described and then only stop the surgery.
Absolutely. So the science is in going till the boundaries, not in really using this instrument or that instrument.
True, absolutely. Thank you, Vikas, for an excellent
Thank you.
demonstration.
Once again, thanks to Prasad, thanks to the whole Mentcon committee for allowing me to do it from here because I could not come there. I have to be at Chennai tomorrow for ISSA Con, that's why. Thank you very much.
Thank you, Vikas.